So my name is Harold Barnett. Everybody can hear me. I'm co-founder of the Institute for Family Caregiving in Durham and a member of the North Carolina Coalition on Aging. And for the past year or so, I'm a member of the North Carolina Serious Illness Coalition's Caregiver and Patient Engagement Work Group. Now, I'm not a hands-on caregiver. That's my business partner, Walitha's area of expertise. My interest is in aging and health equity. Much of the discussion of health equity is abstract, ungrounded, quasi-moralistic. But healthcare is a business. Its operations and its outcomes are highly measurable. We don't need to be talking about health equity as some amorphous ideal. We should be approaching it as a well-framed set of defined goals and empirical metrics. In addition to being a $4 trillion a year business, healthcare has another salient characteristic. It's highly regulated as an industry, and it's largely funded by public dollars. The power of public health administration mostly resides in the states. So that's why my analysis of health equity in North Carolina begins in 1965. I'm an older guy. For those of you too young to remember or may not have been taught in history class or civics class, the Civil Rights Act of 1965 officially lifted the onus of second-class citizenship from Black Americans, especially those in the South. I was in my middle teens when this happened. So we're not talking about ancient history. It was yesterday. Until 1965, the state of North Carolina enforced a political, social, and cultural regime of Jim Crow segregation. That regime championed white supremacy, under which citizens had virtually no rights. Remember, I was a middle teen when all of this was going on. That included the right to health care. Every native Black North Carolinian born before 1965 was born into a landscape of legalized Black inequality and oppression. This precluded their gaining access to anything like quality health care. Today, according to the census, there are approximately 295,000 Black North Carolinians over the age of 60. Every one of them would have been legally denied equal access to health care by the state of North Carolina during their most vulnerable formative periods of development. That's the first takeaway, the role of the state. The state of North Carolina caused permanent damage to an entire generation of North Carolinians through its enforcement of the regime of Jim Crow segregation. Nearly 300,000 of them are alive today and presumably suffering the ill effects of that historic harm. We don't know exactly who or how many because the issue has not been properly researched. The thing that caused me to grasp this generational perspective on health equity in North Carolina was a very obvious racial disparity in the experience of family caregiving. As I reviewed family caregiver research and literature, I was struck by the consistently higher burden of care endured by Black caregivers compared to their white counterparts. To me, this just suggested that Black caregivers were dealing with sicker people. And sicker people, of course, require more care. It followed logically that those denied access to care in their formative years would be more vulnerable to serious and chronic illnesses as they aged. Therefore, 1965, the end of legal segregation in North Carolina, became central to my understanding of aging and health equity. But then I discovered that generational factors alone didn't really fully explain the great divide that persists between Black and white health outcomes. Today, it's popular to frame discussions of health equity around the notion of social determinants of health. In IFC's, we call the Institute for Family Caregiving, IFC, informally. In IFC's interactions and interviews with hundreds of Black family caregivers, we have never heard one caregiver refer to social determinants as a prime cause of caregiving-related problems. On the contrary, nearly every one of them described their interactions with the healthcare system itself as a source of greatest difficulty. This led me to surmise that the healthcare system itself was a central producer of the factors that generate health inequity. At least among Black North Carolinians, it is not, social disparities, but medical and health-related disparities that are the problem. Now, this view was reinforced by consistent testimonies of poor healthcare access and treatment and outcomes by Black people who were not handicapped by social determinants. Solidly middle-class people, upper middle-class people, and even famous people like Serena Williams, they all had the same kinds of issues in the healthcare system as people who would be presumed to have social determinants as major factors in their healthcare experience. These people had resources, educated, had access to the healthcare system, but still they had adverse experiences within the healthcare system. As previously asserted here, healthcare is a business, and the nature of its operations and other features of that business should reveal the cause of these ongoing, as opposed to legacy or generational problems in disparate healthcare outcomes. To get a little personal, an experience from our own history illustrates this factor that legacy racism doesn't always shape these outcomes in care, although they are primary for people who are of a certain age. Recently, I was prescribed a medication known to have some potential kidney side effects. Because this potential kidney side effects was well known, the doctor prescribed that I get regular blood tests to measure my kidney function over several months. Now, my kidneys have always been healthy, and they continue to be healthy despite the use of this medication. However, when I went to my chart to look at my test results, I noted that attached to those results was a racial identifier that I suspected meant the actual test data were adjusted in a manner that is now widely known to decrease the chance that Black patients qualify for top-of-the-line kidney therapies, including dialysis and transplant. This is a technique called race norming. And it's done throughout healthcare, common practice. This race norming has no scientific basis, but it's widespread throughout healthcare. It's known to disadvantage Black patients when it comes to quality of care. When I asked my provider through my chart, and my provider is a large state-supported university-affiliated healthcare system, I got the reply that the test was supposed discontinued because it was no longer accurate and reliable. Well, of course, this test was never accurate or reliable. This practice of adjusting data in this manner is an arbitrary act based on the use of faulty diagnostic algorithms from non-representative research databases. In the 1950s and 60s, when I was growing up, American society was approximately 85% white, 12% black, and 3% other. The other being a kind of basket designation for Latins and Asians and natives, whose percentage of the population was so insignificant as to be considered irrelevant. But that society does not exist today. And that society is not going to exist in the future. So diagnostic algorithms designed around data sources that were compiled during the reign of white numeric and cultural supremacy in this society are ill-matched today with the pluralistic population that we currently have. In healthcare, this mismatch between clinical tools and population characteristics is having disastrous results. Across a wide range of diseases and conditions, it's producing racial disparities in the routine, everyday operation of the healthcare system. I want to point out that my physician who ordered that test for me is not a racist. I love her to death. I know she's not a racist, but she is not in control of what tools she uses in clinical practice. She's an employee of a large healthcare system that makes those decisions. And so we're not talking about individual culpability here. We're talking about tools and practices that are at the heart of the system. So what are we going to do about this? You know, I'm the sort of person who doesn't just harp on problems and set forth grievances. I think if you're intrepid enough to identify or delineate a problem, you should be intrepid enough to propose solutions to those problems. And that's a responsibility I accept. The first thing we have to do, I think, is start with a deeper understanding and more honesty around what is meant by health equity. Because health equity is not an abstraction. It's not just some phrase to be tossed out to check a box. It's a quantifiable measure. It's an indicator of unjustified variance in care. That is to say, it's an indicator of unjustified variance in real human suffering and even mortality. But as one of my work group colleagues has pointed out, you can't measure what you don't count. Today, notoriously, North Carolina has no reliable system for documenting, that is to say, for counting, the prevalence of racially disparate healthcare outcomes, along with identifying their sources inside and outside the healthcare system, because there are sources outside the healthcare system. But even before we get to that, we have to challenge the fact that this landscape of inequality began with the state's embracing of a legal system of social inequality. So, racial inequality in healthcare was established by the state of North Carolina through its embrace of white supremacy and Black subjugation that was only terminated, at least on paper, in 1965, which is well within the scope of lived experience of about 300,000 Black North Carolinians, including myself. Older Black North Carolinians, therefore, face the double whammy of legacy health impacts from Jim Crow segregation, as well as the ongoing institutional forms that are more prevalent today. So to summarize, before 1965, North Carolina had a legally established racist healthcare system created by state government. This system was enforced by the state's subjurisdictions, by its administrative bureaucracy, and it was entrenched by a web of discriminatory social norms and customs. The social norms and customs would never have existed without the legal framework established by the state. After approximately 1965, because as we all know, nothing changes when a piece of paper is signed. So after approximately 1965, the overt legal racism was converted into a less visible, more insidious institutional form, what we have today. So today, as a consequence of all this, we have a healthcare system that's riven by bias in research, clinical procedure, technology design and device manufacture, provider behavior, and many other causes. Changing such a deeply rooted $4 trillion industry is really hard to do. If we really want to begin to make a difference to eradicate these inequalities in the way that our healthcare system operates, that's what we have to aspire to do. So I've asked Heather to put on the screen some recommendations that I've developed to offer to various groups, and suggested they encourage their representatives to consider legislation, resolutions, and other means to begin to enact some real, substantive, meaningful changes in the way our healthcare system operates here in this state. And the state is the jurisdictional level at which changes in public health occur. And it's important to get that jurisdictional target correct. It's the state where these changes have to occur primarily. I want to apologize again for my computer issues. Luckily, I have some help getting that squared away, and I was able to make this presentation.
Thank you. I want to make sure I'm on. Great. Harold, thank you so much. Great outline of issues. I don't want to talk too much. I want to throw it right over to Dr. Baker to share some commentary on what was shared, and then as well as her focus on in her research. And I see the head shaking.
Yeah. I'm like, how dare you have me go after Harold? I have to be very transparent. When I initially read his commentary and read his story, I was like, this is exactly what I would have said. But he said it so much more eloquently than I could have ever imagined myself presenting. And again, he mentioned about the healthcare system and his own personal story and interacting with the healthcare system. And, I have my own story as well, but I think, when he mentioned about social determinants of health, I think that the healthcare system is a social determinant, although we may not necessarily classify it as that. Again, it really goes back to the figure that I showed in a previous presentation with the Healthy Aging Task Force, is that you have these different levels. And again, I think the healthcare system is at that upstream, determinant that, has an impact on that middle and lower stream outcomes. And again, when we talk about race norming, Harold, I read your piece about that. I heard about it. But again, my mouth it dropped open when I actually saw the different stories behind race norming, and thinking to myself, this possibly can't be happening still. But again, even when I give presentations, I think my angle is more out of frustration and asking the question, why in 2022 are we still having to have these conversations? And I get frustrated sometimes, not saying that what we're doing right now is frustrating me, but I want us to start actually thinking about that question. Why are we still having to have this conversation with all the technology, all the advancements that we've had throughout the centuries, throughout the decades? We are still having the same conversations that Harold mentioned back when he was growing up in the 50s and 60s, when I was growing up in the 70s and the 80s, and heaven forbid when my kids grow up in the decades to come. You know, I think that this is more like a roundtable type conversation. And although, you know, we're deemed, so to speak, as the experts, I think that we need to hear from a larger audience as to why we're here. And even in responding to Harold's commentary and his recommendations and suggestions, and I don't know how much more time we have, but I really can't add anything else other than what I did, you know, when I earlier to speak with the group about the research that I do, and, you know, the focus of my research, and, you know, going beyond the more traditional way of how we define and look at disparities and equities. And again, I even go back to the fact of what I mentioned before. We know disparities exist. We're well beyond that conversation. We know that differences occur. But again, it goes back to the question is why? Why do we continue to see the same things happening over and over again? Why do we have to have these conversations? Why do we still have to have these conversations? We know it exists. And again, I think with Harold's feedback, it'll be great if we could have a larger conversation around the next steps and what we need to do moving forward. So again, I'm not going to add much more than what he already put out there. I think, as I mentioned before, he hit it on the head. I mean, it's exactly what we need to do and consider moving forward, particularly in talking about issues around equity. Let's not talk about disparities anymore. That ship has sailed. We need to move beyond documenting differences, giving the stats on differences. We know that exists. What are we going to do about those numbers? And I think that's part of this conversation. So I'm going to stop there and would love to hear from the audience, and even hearing more about, you know, what Harold has to offer with regards to this conversation.
Great, and thank you. And we do have a good, you know, we can go a few minutes over. We have about 10 to 15 minutes. And moving from that why frustration to the what now, as I look at the boxes, I see a group of providers, I see a group of advocates, I see a number of researchers, and so would like to open it up to others for questions about what now, how do we move forward to inform either clinical practice change, our research methodology change, what we're advocating for. And I see a lot of thank yous in the chats.
Well, Heather, I want to say to everybody here, this is not personal. People come up to me all the time and they say, well, I wasn't even alive back then. I'm not responsible. I'm not a racist. Of course not. You're not. Nobody's calling you a racist. Nobody wants to accuse you of any unbecoming behavior at all. You didn't have to be alive. No individual can impose a social system across a society. That has to be done by the highest authority, which in the case of North Carolina would be the state. You're not personally responsible. You're not personally a racist. You're part of a legal system, or the inheritor of a legal system that was imposed by the most powerful political entity within this jurisdiction, which is the state. So you're not personally responsible, but the state is culpable. So we need to make that distinction. It's not about, individuals being racist and all this sort of thing. My doctor is not a racist. She has to use the tests and the techniques and methodologies that have been contracted by her employer to use. And if these tests are racially biased, they need to be eliminated from the healthcare system. The state can do that because the state funds the hospital system.
So
the state can simply say, we're not going to fund anything that discriminates.
Sorry to interrupt. I know in previous email interchanges, has there been a list that's been compiled of using the example of the race norming? And you shared in through some of our email exchanges back and forth. It's not just the kidney test. We've heard a lot about it in the news with football and the concussion work. Is part of it getting really specific? You know, here's all of the, I mean, that's just how my mind sort of works, part in practice and part in research. So we know what we're advocating on a really specific level, saying, look, here, so when people, if they want to deny it or they don't know how to change it, say, here's the specific things that we keep capturing. Is there a list? Could we help to contribute to that? Are we seeing it with our patients and our clients?
This can be a totally fact-based discussion because the information is out there. I've spent the last 8 years researching it and coming to understand it because that's not my background. I took this on as a personal mission. The information is out there. It can be a totally fact-based discussion. And this is something that I think the Serious Illness Coalition might want to take up as, you know, part of its mission to identify these tools and practices, methodologies, and other sort of embedded factors that are generating disparities within the normal everyday operation of the healthcare system. Then we can start talking about, you know, housing and not being able to buy veggies and all these other things that are the social determinants. Most of the problems with health inequity are embedded in the healthcare system.
Well, and I think it's a challenge. I know just as the archivist or trying to keep track of when we look at our strategic plan, that health equity recommendation that came out of the IOM and all of our conversations addressing health equity is a continued theme, but how does it get operationalized when we talk about advanced care planning, when we talk about caregiving support, when we talk about Medicaid expansion, you know, when we're talking about all these issues, both in our programmatic work as well as the policy, trying to really tease it out. And so I challenge all of us, and I know some are marinating on this conversation and some have been really living it intensely, but I let this be an ongoing thought process of how to include it. So I see from Shane, do you feel like a conversation around white discomfort, the conscious and unconscious bias responses to situations involving racial diversity or interactions with BIPOC individuals should be included in reviewing systemic oppression in the absence of skills? And okay, this goes on in recognizing affirmations of bias, especially in decision-making, such as in task forcing to death initiatives or not investing, can help reduce those practices.
I can speak to that if you want, just real quick. To explain that. I work with a lot of executive directors in nonprofit sectors. And so one thing that I presented on in the past is white discomfort, because oftentimes decision makers aren't aware of the biases or don't know how to respond. Just because they don't grow up with the same skill sets, right? When we talk about race and racial diversity, they don't have those skill sets in place. So they can't always hear themselves, and they can't always know how to respond when they're listening to other people who can't articulate their own discomforts and how they can sort of move forward. And that systemically plays out in nonprofit sectors in a way that kind of people underfund initiatives that help in dealing with these challenges. In task forcing things to death is something that comes up a lot in those conversations, and that we will talk about it until eventually it goes away so that we don't reduce it. And I bring this up because, again, Harold, I think really powerful statements around systemic challenges here, and that some of these systems get affirmed through decisions at little levels, like lower levels, all the way through upper levels. And so how those get addressed. And so I was curious your thoughts on that.
Well, the other thing to realize is that the healthcare system can't continue the way that it is. It's not viable the way that it is. We have a healthcare system that operates from a 1950s and 1960s culture. That's why I made the point about the 85%, 12%, 3%. That's not the society we live in anymore. And increasingly, healthcare is based on genetic research and genetic products, genetically based products. And so if you're drawing from an 85% white genetic database to create products for a society that looked way different from that, you're going to have a healthcare system that doesn't make any sense. So it has to change. And one of the things that we have to change is how we think about our society, because we don't have a white dominated society anymore. We have a pluralistic society, and we need to start thinking in terms of pluralism, not diversity, which is just another word for tokenism, and not in terms of inclusion. Including into what? A messed up system? We don't want to be included in a messed up system. So we're not talking about diversity. We're not talking about inclusion. We're talking about reorienting the way we think about the society, and the healthcare system is just a reflection of the society. So we have to think about how we need to change the healthcare system so that it operates and reflects the realities of our pluralistic society. And this doesn't just apply to race. I know about race, that's why I talk about it. There are things I don't know about, so I don't talk about them. But I read in the New York Times yesterday where this same attitude applies to people with disabilities. The healthcare system treats people with disabilities just like it treats Black people. That article is in the New York Times from yesterday, and I suggest you read it.
So I want to comment on two articles that are being shared in the chat, and I've learned if you just click on it, but don't actually read it now, you can have it open for after this closes. The first, I want to thank Jerry for sharing the American Academy of Pediatrics. They have their policy statement on eliminating race-based medicine with policy recommendations. So thank you so much. And then Christine just shared whiteness at work and with some helpful resources. So thank you. I want to check in to see, are there, clearly this conversation is going to continue. And one of the questions that Virginia and I were sharing with Dr. Baker and Harold Barnett before this, which is, what should we all be doing to lead this effort as opposed to relying on people of color to be leading the effort? You know, it does not need to be the people of color who are researchers or advocates. Where's all of our voice, especially those of us that come and we're looking at all those, in this case, with those with serious illness caregiving. So how do we use our voice? And I'm seeing, sorry, here's another article to look at, Hidden in Plain Sight, Reconsidering the Use of Race Correction in Clinical Algorithms. So clearly there's a role for all of us to be looking in the platforms that we have. I don't want to say silos, but and I know in just a few moments we're going to break into our work groups and let this help to be a guiding issue for those discussions. Are there other questions or comments? A lot of praise and gratitude and thanks to both Harold Barnett for sharing both big picture systemic as well as really personal reflections, and Dr. Baker for sharing now, as well as I really do call your attention. We have it recorded, the Friday Facts. Dr. Baker shared with us back August, I think it was August 16th, excellent, about her research approach and her perspective.
And Heather, I thank you for the invite. I mean, although Harold provided lots and lots of very important information, and I wish I could have added more, but you know, part of this discussion as well, you know, you asked what can we all do? I think we need to get out of the mindset that it's an us versus them. And I think that is part of the discussion as well. You know, we tend to have this separation, but in recognizing that we can all, you know, be part of this discussion, I think that is, you know, definitely a start. Stop making it's you, it's them, it's not me. It's not my issue. And I think sometimes, not saying all of us, but there's a significant number of individuals that continue to have this type of mindset, which sort of has that dividing line that, you know, I can't do anything about it because it's them. And it's not me. And even when Harold was talking about his primary care provider is not a racist, again, many of us have that mindset. I'm not a racist, but sometimes the way that we think can follow that racist sort of type persona, or even some of the actions that we have. And it's not just race alone. that we need to focus on. But I know that's like the primary variable that's part of our conversations. But, you know, I want to leave with, you know, the members is, you know, getting out of the mindset us versus them. And then also really think about the question that I asked, why are we still having this conversation? And I think part of moving forward is you personally being able to answer that question.
And most importantly, we have to remember that healthcare is a $4 trillion a year business. It's not some benevolent charity. So what is happening right now in healthcare is we're incentivizing the production of health inequality because people are being paid in a very profitable industry to produce these outcomes. Where are the incentives for reducing health inequity? Where are the economic incentives for doing that? They don't exist. So that's one of the things we have to move away from, this moralistic discussion to a discussion of business. What are we incentivizing? And what should we be incentivizing? And restructure those incentives accordingly.
Well, this has been really helpful. And one of the things that I love about coalition work, and our coalition in particular, is that we do have this collective ability to have a collective impact and having these conversations. And I think, Sue, just, I know the chats are kind of blowing up here. As we think about our own responsibilities and then how we can bring it together, and Sue asked the question, how might the coalition use its influence and networks to bring the healthcare system leaders to the table for this discussion? I would say I consider many of us those healthcare leaders. And so I think it's important that we're having these conversations now. And clearly there's a whole group of other leaders. And that is part of our charge now, to think, what can we do as a coalition to help really address health equity, and going, as we keep saying, like using surface, going much deeper, and I guess, and then moving past the why, and really questioning the why, but moving past it to then say, what can we get done and how can we make systemic change? So I think I'm looking at one last comment before power of inertia. State of Delaware has an incredible example of eliminating colorectal cancer. Black-white disparities. Okay, so there's clearly things for us to be looking at. What I will ask my lovely colleagues, Virginia and Jessica, if we can just keep track of all of these links to great articles. When we send out the next communication after this discussion, why don't we go ahead and try to include both those links, as well as, Harold, if it's okay, the fullness of your comments, as well as your recommendation. You're muted, but I'm going to think you're saying yes.
Yeah,
yeah,
I
okay.
am saying yes.
Okay, great. And I have the pleasure of having it printed out, so I already have advanced. Really, I want to thank you. I want to thank Harold Barnett, Tamara Baker for this conversation, one of hopefully many. And yes, so we don't have enough C-suite healthcare leaders on the call, so we're going to discuss that. Oh, and she sent that to me, but we need to really look at the fullness of our colleagues. Thank you so much. What we're going to do now, with hopefully this all fresh in our minds, is we're going to break into our work groups. I did want to make an announcement per messages I'm getting from Christine Lau and Linda Darden, that the clinical practice work group and the advanced care planning work groups are actually going to meet collectively for the first part to talk about their symposium work. So for about 15 minutes or so, and then Jessica will separate them out, but those two will be together. But I want to go ahead and close out again with gratitude and praise and thank you to Harold and Tamara.